Hi, everyone. Thank you so much for having me here today. My name is Nicole Hardy. I'm a fourth-year medical student from the University of Connecticut, and I'm very pleased to present our group's research on treatment discontinuation in desmoid tumors and factors associated with better outcomes after sorafenib discontinuation. Here are our disclosures for our group. So a little bit of background about our study. We conducted, a little bit of background about the disease. Desmoid tumors, as you all know, are rare locally aggressive neoplasms. They have no metastatic potential. However, they can have significant morbidity in patients. Active surveillance is typically first line, but systemic therapy is used for progressive disease. Sorafenib has been used in that circumstance. However, the optimal treatment duration and discontinuation strategy are yet known. Therefore, our objective was to evaluate outcomes after sorafenib discontinuation and factors associated with durable control. So here are some images from our study. So the row A represents one patient, and row B represents a contrasting patient. So the top row shows a patient that had a continuation of response after discontinuation of therapy, while row B showed a patient that unfortunately rebounded after stopping treatment. You can see in the top row that there was originally a 9.3 centimeter desmoid tumor that in the middle column, the first row, you'll see decreased to be 6.3 centimeters in size after 15 months of treatment on sorafenib. After 51 months of sorafenib discontinuation, there was further decrease in size to 1.7 centimeters. In contrast to the second patient, we see on the bottom left a large heterogeneous mass in the left hip. This decreased in size in T2 signal after 26 months of treatment on sorafenib. However, after 28 months after discontinuation of sorafenib, there was unfortunately a rebound in growth, which is the bottom right image. Discussing a little bit of our methods of this project, we conducted a retrospective multi-institutional cohort study with patients between 2005 and 2024. Patients were included that had histologically confirmed desmoid tumors treated with sorafenib between those days, who subsequently discontinued therapy without immediate alternative treatment. We collected several different data points, including demographics, tumor characteristics, treatment duration, adverse events, discontinuation reasons, as well as imaging response using the RECIST 1.1 criteria, which I can understand is an important point of discussion. And we collected those data points at initiation and discontinuation. Our primary endpoint was treatment-free survival, and we also evaluated progression-free survival. We also provided a consensus statement developed by 6 sarcoma specialists at multiple different institutions, and also two patient advocates who also provided their perspective to develop a statement based on their opinion and personal experience. Digging a little deeper into our cohort, we had 48 patients. The median age was around 41. The median time on sorafenib was 17 months, and the median follow-up after discontinuation was 28 months. 79% had stable disease or partial response, while 8% had progression of disease. Around 2/3 of patients who discontinued for other reasons besides toxicity, including patient preference, provider preference, or insurance. So only 1/3 approximately discontinued due to toxicity. Talking a little bit about treatment-free survival, there was one predictor that stood out. Duration of therapy, being 6 months, was shown to be statistically significant. We saw that for those who were on sorafenib for less than 6 months, the median treatment-free survival was 10.1 months. However, for those who were on sorafenib for greater than 6 months, we saw the treatment-free survival was 54.5 months. Cutoffs at 1 year and 2 years for treatment-free survival were not shown to be statistically significant. Additionally, progression-free survival at 6 months, 12 months, and 24 months were also not shown to be statistically significant. Looking at adverse events, overall, diarrhea was the most common, followed by palmar-plantar erythrodysesthesia, which was also the most common reason for those who discontinued. Hopefully you guys can see these graphs. So the top left shows the Kaplan-Meier curve comparing patients who were on sorafenib for less than 6 months to those who were on it for greater than 6 months. And it showed significantly improved treatment-free survival and provides good evidence for a minimum treatment duration of 6 months. Another factor that was statistically significant is in graph E. Larger tumors at discontinuation were associated with worse outcomes. This reinforces the importance of tumor shrinkage or stability before stopping. We can see that those who had an increase in tumor size had worse treatment-free survival compared to those who had no increase in tumor size. Looking at progression-free survival, we saw that patients with progressive disease at discontinuation had the poorest outcomes. Stable and partial response groups fared much better. This was statistically significant. We can also see that for the 6 months, 12 months, and 24 months, there was no statistically significant difference between those groups. However, the small numbers in our study do limit interpretation. But again, we suggest that the duration does matter. But that perhaps there's diminishing returns after a certain point in time. We also provide here spider plots. On the left, we can see patients prior, and on the right, patients after discontinuation and their response. What we can note is that individual tumor trajectories before and after discontinuation showed that many patients maintained stable or improved disease following sorafenib discontinuation. And something that I think is important to note is that around a quarter of patients, we had 13 out of 48, so 27%, required subsequent treatment after sorafenib discontinuation. The most common treatments were re-challenging with sorafenib. 6 out of 13 patients, or 46%, were re-challenged. Or they were given nirogacestat, 2 out of the 13, or 15% of the patients. No patients on either of these therapies required subsequent treatment or subsequent change in treatment. The consensus statement that we developed showed that sorafenib for at least 6 months is ideal, and that perhaps extending to 1 or 2 years is something that we should consider. We also note that durable disease control is seen more often when there is tumor shrinkage or symptom improvement. Prolonged therapy is not always necessary and may be safely discontinued, or at least considered to be discontinued, under the following circumstances. So 1, if the tumor is stable or regresses, if the side effects become too burdensome for the patient, or if there is financial toxicity or severe impairment of quality of life Those are all reasons that discontinuation of sorafenib can be considered. Key factors that can influence the decision are proximity of the tumor to vital structures, the severity of the symptoms, radiological changes, and how the patients are tolerating the therapy. In summary, both treatment duration and tumor response to sorafenib predict future treatment need. Completing at least 6 months of therapy reduces the likelihood of requiring further treatment, with 1 to 2 years being an ideal duration in patients. That said, prolonged therapy is not always necessary and can safely be discontinued in some patients with stable or regressing disease. And as always, treatment decisions are individualized and should be made via shared decision-making. I'd like to acknowledge a few people. So one, I'd like to thank all of the patients who gave us their data and allowed us to use their data to conduct this research. Specifically, I'd like to thank 2 patient advocates who are from this organization and also the Brazilian Association of Desmoid Tumors, who helped create the consensus statement. And I'd also like to thank Dr. Costa, who gave me the opportunity to present here today. And with that, I'm happy to do my best to answer any questions.
I have a couple questions, if I may. Over here, Nicole.
Oh,
straight ahead. Hey.
Hi.
First, thanks so much for doing this project and working so hard on it. It's, so many important data that you've collected that help all of us understand better how to care for patients. My question was for the PFS or the treatment-free survival curves that you showed, the top left one where you've compared the less than 6 months. How many patients are at risk? The red line, how many patients were in that group?
Let me zoom in on the graph. I have the risk table below.
No worries.
I think it says 3, but the font is quite small on the computer.
Okay.
But it was quite small. So in general, I guess this speaks to a limitation of our study, was that unfortunately the number at risk was oftentimes very, it's moving for me, thank you. If you don't mind zooming in on the risk table at the bottom of the graph A, I would appreciate that. Yeah, the numbers were quite small. And so, for example, that was one reason why we suspect that for 12 months and 24 months, we didn't really appreciate any statistically significant difference, was perhaps because our sample sizes were too small. And then I think they zoomed in a little bit on the risk table there for you to see. But if you still can't see it, I'm happy to pull it up for you after.
Oh, I think you're exactly right. I think it says 3. Yeah.
I was going from memory, so I was hoping I was right.
Very good. So do you know why those patients stopped treatment? Was it for progression on sorafenib or toxicity, or what was the reason they came off so early?
For those specific patients? So I can pull up the data set and identify the exact reason for those patients. We actually have more detailed breakdowns of that data, and I can give you a better answer after, if that's okay.
Yeah, of course. Sounds good. My other question, if I may take one more, for the patients that were re-challenged with sorafenib, do you know if they responded to sorafenib again?
Yes, so that's a great question. So none of the patients who were re-challenged with sorafenib needed to change treatments after that, at least up until the follow-up point of the study. So they all did well, and they were responding on treatment again.
That's a great point, actually, because I think then, maybe if we stop treatment early and there's recurrence, then it could be restarted. But if the patient does well off treatment, then that's wonderful. So very good. Awesome data. Thank you.
Thank you. I think I saw, yes.
Excellent presentation. Have you looked at tumor location or beta-catenin status with discontinuation or response, re-challenge?
Excellent question. We did not collect that data for this analysis. However, I think that would be a wonderful next step for us to do next time.
Maybe I missed it. What was the dosage of sorafenib? You started quite early in 2005, and at that time the recommended dose was 800. Later it was 600. Nowadays it's 400. So what were the dosages used in those patients?
Excellent question. I wish Dr. Costa, who's the oncologist I work with, were here to field that question. What I can do is pull up the patient charts and get back to you with that answer. 400 mg, okay. I think is what she said.
Then have a comment. Did you send those data to the German regulators last year?
I'm sorry, could you repeat your question?
Did you send your data to the German regulators of drugs last year? The Germans decided last year in August that they would allow sorafenib for the treatment of desmoid tumors. It's not registered, therefore, with a dosage of 400 for 6 months, and that has to be reimbursed by the insurance companies. So this is the perfect hit. So I'm suspecting you sent your data beforehand. Thank you very much. We got a lot of answers from you.
Thank you.
No, I just want to add, no one's published anything like this before, so I hope you will publish this data. It's very important.
We're working on it. Thank you.